discuss reimbursement and collection, billing. Dr. Ayham again, please join us to the stage and introduce your panelists.
Thank you all. For the next session, it's actually a personal interest of mine. I've always, over the past maybe 10 years, wanted to see all the stakeholders on one place talking to each other at the same time. I've been positioned in the middle for the past 5 years, and I meet all the stakeholders differently. And there is, of course, different ways into looking at the same thing, but at the same time, when you look at what they say, they all talk the same language, but we're just probably not there in how we implement all as one implementation which fits all. In this session, we're going to discuss basically the pricing which is the billing and reimbursement. It's all about the pricing of healthcare services, which I think is of importance to all the stakeholders, including the investors, as Dr. Ahmed has said, that because it sets what investment is, but it's also equally important to everybody, including the public, because it affects the cost of healthcare, what we're talking about. Let me start first by inviting our panelists. I would like to welcome Dr. Haidar Al-Youssef. He's the CEO of the Health Funding from Dubai Health Authority. To stage. Dr. Haidar, good morning. It is afternoon. Good afternoon. Mr. Marwan Narisi is the Director of the Health System Finances from the Health Authority of Abu Dhabi. I don't need one. Engineer Subhi Batarji, of course, he's the founder and the president of the Saudi German Group of Hospitals. Dr. Sami Al-Aom, Chief Strategy Officer from Al Noor Group of Hospitals in UAE. Mr. Andre Dawood, Chief Business Officer from NextCare. And last but not least, of course, Dr. Sharif Mahmoud. He's the Regional Head of Healthcare Operations from AXA Gulf. Okay, so what we did for this panel, for this discussion panel, is we have talked with each and every one of you. You have kindly given us time, and we've talked about this subject. We've got your views, we've published them as well. I hope most of them maybe have read what you have to say. We're going to try and gear this session as much as possible in order maybe to have some kind of a platform whereby if there is any, we have the same objective, of course. I know everybody has the same objective, but maybe different ways of implementing it. So maybe we can come up with, and we'll try as much as possible to come up with maybe action points on this. Let me start with Abu Dhabi. Okay? We'll start from you, Mr. Marwan. Okay? We have talked about the pricing. Okay? We have said that there is a cap on the multiplier prices simply because which makes all the sense, simply because there is a high funding by the government, goes between 60 to 70%. All right? At the same time, the private sector, because of certain of this cap, sometimes they are coming and saying, this is not very much attractive for me as an investor, all right? Because certain prices in healthcare services is not giving sufficient reimbursement for the service to be provided. What's your views on this?
First of all, the basic price list. The basic price list. I'm pretty sure not all the services listed there is not attractive.
Some.
Is not attractive
some.
For investing. We understand that we have certain issues. And as of now, the Health Authority is going through an exercise to reviewing the basic price list and to look at these issues and to find solution for these issues. But in general, the basic price list, the ceiling and the floor, as stated in the in the provider contracts, standard provider contract, I can say it's very attractive. But we understand there are issues. One of the solutions is already went out. I don't remember what's the circular number when we did the DRG weight update, and we couple it with adding the consumable cost for certain services. Other measures, other solutions are coming through the current review of the mandatory tariff by mandatory price list. We're not going to call it mandatory tariff anymore, by an external
supplier,
external
third party,
independent third party. And this third party, if I'm not mistaken, and the healthcare provider, they can correct me, they already, this consultant already is in contact with the healthcare provider in Abu Dhabi to hear their part of the story.
We have the healthcare providers in Abu Dhabi, one of them, one of the largest, of course, one of the largest, and we would like to hear your part of the story.
Sure, happy to. I think the key here is to strike a balance between regulation of pricing, but leaving the market competitive and interesting enough for people to invest in new services. And I think HAD, for the most part, has managed to achieve that in Abu Dhabi. So for those of you from other health systems, you heard from Mr. Marwan, there's a minimum and a maximum, which I know in many systems you don't have such boundaries, but it's a very comfortable window in which to work in. At the same time, I'd say the vast majority of services are worth investing in, even for something like the basic product. For those of you from other systems, that's a product geared towards workers, those making less than 5,000 dirhams a month. Now, there are some challenges, and so yes, there are some services where it's not worth investing in, even for other segments, not just for the basic product. But I think the key is for the regulator to actively converse with providers, which is something we have, fortunately, and in some instances to come up with a creative way to eliminate this barrier, or eliminate what makes it not so interesting to invest in something. And again, Mr. Marwan cited an example of that. So I think this balance is key to strike. I think in Abu Dhabi we've progressed a lot in the last 7 years since the implementation of universal coverage, and there's still a little bit more to go.
Well, I thank you, Dr. Sami, continuing also on the same topic, but not on the regulator side of things. When we discuss this, the pricing side of things, we talked a little bit about price increases. And my understanding from you is that there is certain price increases which insurance companies are taking these price increases, reflecting it in premiums. But premiums are being increased at a higher level than what the price increase is. Would you like to expand a little bit on this?
Sure. I mean, you have two effects happening at the same time, right? You have pricing, inflation.
From the provider side of things.
And then you have utilization, which happens on the member side. Some of it will be supply-driven sometimes. I think for us, the key component is pricing because of our unit cost, right? So yes, utilization gives you a little bit of efficiency. In mature hospitals, you typically wouldn't see that. And then you need the pricing to cover your own inflation. So staff costs are a big issue for us. 1/3 of our costs is medical staff. We see physician inflation annually, anywhere between 10 and 14%, which is massive. We hate to see that, but that's a fact of doing business here in Abu Dhabi, or even in the UAE perhaps. And people need to understand that that's what it takes to deliver service. So that has to be reflected in pricing of providers, which in turn is reflected in pricing of premiums.
Do you think that it should reflect the prices of premiums, or do you think that maybe payers need to work around this? Do you think that they should actually increase the premium?
I see financing flowing through. I mean, why should payers have to absorb it, right? And they have their margins to protect as well, just like providers have their margins to protect. So that's going to flow through to the employer. Think about the average spend on healthcare in the UAE. It's about $1,000 a person. And our leadership wants us to attain higher standards, right? We look at the West as a comparator usually. If you look at a place like the US, the average spend is $8,000. In Europe is $4,000 to $5,000. I'm not suggesting we need to be at 8. I'm suggesting that 1 is perhaps not sufficient to attain that.
Thank you, Dr. Sami. Mr. Andre, what do you think? You represent many of the payers in UAE.
Good morning. Good afternoon, actually.
Exactly.
I would like to carry from what has started there, and in terms of the base price that has been established in Abu Dhabi, I think that's a good start and a good referential. I believe we could also add to that some sort of criteria in terms of quality checks, in terms what could or who could apply which factor. So we could check some boxes in terms of saying, okay, if you check those boxes, you go to a certain tier and you can go into multiplier 1 or 2 or 3. And I understand also from the upcoming Dubai system now, we're looking at metrics coming into the picture in terms of success rates, the facility type, and so on and so forth. In terms of payers retaining the inflation, it has to be passed back, and at the end, who suffers is the employer and sometimes the beneficiaries, and the whole economy at the end is paying for inflation.
All right, thank you. Dr. Haider, well, before you come, there was a discussion about pricing, and there was many comments saying that one of the good things about Dubai is that there is no regulation on pricing and it's an open market.
There will be regulations.
There will be regulation on pricing, by the way.
But it will still remain one of the good things.
Let's hear from you. I know you have this news.
This is a piece of news that obviously that's going to be coming out soon from the DHA. And in this component, the DHA is obviously trying to strike a balance between regulating prices and i.e. ensuring that the cost of healthcare does not really inflate, with the same time sort of keeping the free spirit of the market of Dubai. The government of Dubai have chosen private health insurance as the model for financing health services in the Emirate of Dubai. So this is now the way we deliver healthcare services in Dubai. What we say is primary focus is the patient. Along that journey of delivering care to the patient, some providers will make some money, reasonable amount. Regulatory control system needs to ensure that this equilibrium and the sustainability is there. So the Dubai model will control price increases rather than sort of set prices. Market equilibrium in Dubai has been reached through years of basically the relationships between payers and providers. Some of these principles on which it's based are correct, some are not so correct. But at least we have now stability in the market. The market has reached that level of stability through this process. So we will not upset that immediately. We will start by introducing models or mechanisms of controlling price increases that will basically look at external factors like inflation, cost on doing business, all of these factors basically, and it will start to address internal factors as well. So outcomes, quality outcomes, clinical outcomes, patient satisfaction outcomes, and slowly as we move with our Ijada project, as you're all aware of, it's a project that will publish all of these outcomes to the end user. So the patient ultimately is now aware of those outcomes and indicators and how well is that facility performing. They also then start to have a say, kind of forcing in some way a price differentiation towards those with better quality versus those with lower quality, regardless to the sort of initial price.
Let me just ask you, sorry to interrupt, before we move into the quality side of things. So I am a provider now in Dubai. When this comes, I will have, my understanding from you is that I will have to submit a request to DHA that I want to increase my prices because X percentage.
Correct.
And DHA will either approve or not approve. It's a process with DHA.
Yes, absolutely. There will be an application process that has some prerequisites and that requires some justifications, basically.
Great. And let's assume that DHA rejects, then I cannot go to the insurance and increase my prices.
Correct.
All right. Let's assume that DHA accepts. Can I just go to Andre and tell him this is what it is, or I will have again to...
You still need to negotiate with
because that's a hectic process.
Yeah, you still obviously need to get the payers in, but at least with the DHA accepting your new price structure and acknowledging that you have a, you can't say we have a free market and I'm allowing providers to kind of come in with the prices they want and then force insurance companies to take those prices as well. So if it's a free market, then it has to basically be a free market all in all. So our key concern is obviously controlling the entry level, because with the basic benefit package, this is a volume product, this is a very, very high volume, low margin product. So at that entry level, we need to ensure that health services in the Emirate of Dubai continue to be affordable, and that market caters for it, and that doesn't really increase the cost of doing business in the Emirate of Dubai. In the high end as well, there will always be some people that, besides clinical outcome, require a more fancy facility and much more sort of comfortable, more along the lines of hospitality type customer services. There are people who are willing to pay for it and insurance companies who are willing to provide that coverage, and that's absolutely fine. And this is the spirit of Dubai, and we will always maintain that. We are basically addressing the areas of concern through our price regulation model and ensuring that the increase in prices is not really exaggerated in any way. So it's a very dynamic model that tries to address obviously the external influencers over price increase requirements, but in the same time we'll start to bring in elements of quality into that. So sort of it will link ability to increase prices with adherence to DHA's regulations and with adherence to quality standards that are expected from the Emirate of Dubai. If you look at the health insurance law, the Dubai Health Insurance Law, it's one of very, very few pieces of regulation that have the goals within that law. Most health insurance systems look at basically providing coverage. Dubai law says basically that this law is not only there to provide coverage to people who are not covered, but it also aims towards increasing the quality of service of the health system in the Emirate of Dubai. And that's why you will see that all of the regulatory tools that we introduced gear up to that. So you see insurance companies starting to operate in a way, perhaps for the last 30 years they haven't done that. And I don't know, Andre, maybe you can reflect on this working with insurance companies. For the first time they have to actually look at complaints log and ensure that complaints are resolved. For the first time they have to actually work in a slightly different way. So all of the tools, all of the regulatory tools we introduce, whether it's from a price regulation or all the other different components of the regulatory system, are there to increase the quality of the healthcare service in the Emirate of Dubai, with, in the same time, preserving this free market spirit and all of the competitive advantages that the Dubai market has over many other markets.
So it's a regulation along with other tools which is aimed few calls and asking about this particular process, okay? And they are saying if
it
they
will be announced officially soon.
all right, but they were saying that if there will be no acceptance from insurance, it's like a second step. So there have to be two steps, one after the other, from the providers. Okay, all right. Thank you so much. I think Engineer Subhi, we would like to hear what you have to say about of your
I
experience.
always tell and say that I always like to bring the Saudi experience because that's where we come from. Now, the first comment which you have made about not talking to each other. We are talking to each other in Saudi Arabia on different levels. We have established at the Chamber of Commerce in Saudi Arabia a healthcare committee where people come and meet every month and talk to each other. We have also established on a country level, the Chambers of Commerce Health Committee, where all the 150 hospitals, private hospitals in Saudi Arabia and healthcare providers, representatives come and discuss issues that is related to the industry. The same thing for insurance companies. We hold meetings with the insurance companies on a private level and on a group level. So not only that, we also have meetings with the Ministry of Health. We have two levels of meetings, one on a country level, one on a deputy minister level. So we are talking in Saudi Arabia, and I love to see these practices implemented here because not two people in this room talk to each other. We have tried to establish this platform of communication, and people thought that we are regrouping and we are trying to control pricing, and very much misunderstood. So that's one point. The other point, personally, and our group, when we speak about pricing, we are very shy. We feel that pricing and control of pricing is a socialistic, communistic model, and it has failed. Now, but when Dubai start talking, I step back. Why? Because Dubai has always shown us that they are different. And Dubai has always shown us that they come with the private sector in mind. So I'm not going to discuss anything about what they have in mind, but I'm sure that they will have something most probably workable. But I am also warning that this is the deep sea. When you talk about pricing in healthcare, this is deep waters. Thank you.
Thank you. Dr. Sharif.
Let me just
Sure,
say something.
please. That's right.
I think this accusation was made twice now that actually people don't talk to each other, and maybe yes, there should be more talking.
I didn't say they don't talk, but I said
no,
that.
because as a regulator, and the Dubai model has actually been developed through a process of consultation all the way from back in 2009 on one-to-one basis, different forums, different working parties and working groups, and this has basically, it is embedded in how we've developed our model in consultation with everyone.
I mean systematic meetings.
So perhaps more official bodies.
More official bodies.
I understand that, but it's also not a completely isolated market, perhaps. So for those of you listening to this for the first time, don't worry, it's not that bad. Sorry.
All right, Dr. Sharif. Moving a little bit on pricing, because we are talking about pricing, but you and me, we talked about something else, which is utilization. All right, because it's not only the price of the service itself, because you can probably go and regulate the price. But what about utilization? You cannot regulate the utilization of this service. And if the utilization is high, or if it is, let me put it, not high, but not medically necessary, then you again fall into the same trap of non-financially sustainable model.
Well, talking about utilization, over the past years, utilization have been accused to the user themselves. So the patient, when he goes more frequent to the provider, he asks for more services, which is actually not true. And if you look about the structure and the engineering of the pricing of everything, utilization is embedded there without us even knowing it. And let's look about a very simple example, a very simple blood test that's done everywhere in the same way, and it doesn't need any medical skill, like the complete blood count, a very simple blood analysis. The price of the complete blood count in any provider, you have here the cost of the technician, the cost of the machine, the cost of the serums used, the cost of everything used. So the more frequent you're using it, the more turnover, the more running cost is going to be imposed on the provider. And eventually, this is going to be plugged in the pricing. And in this way, the economy of this provider is more vulnerable to the inflation in the market. On the other hand, knowing that the investment behind healthcare in terms of opening a facility requires a very high entry level economically, eventually this is a business model that needs to break even end of the day. So it might cascade down some culture of practitioners driving utilization. So we can see it, we can experience it every day in the market. It's not an accusation for anyone, but it's true. When you go for a simple visit to a doctor, he prescribes lab investigations, you come back to see the blood test, he gives you some medication, then you come back once again to see what is the end result of this condition and what is the end result of this treatment path. It's true. However, we can understand the rationale behind it. We can understand perfectly that some element is behind being worried about the commercials. Some element is there about being worried so the practitioner is more into the defensive way of practicing medicine rather than going through the normal internationally recognized clinical care pathways. And the one who's paying for that is actually the user, although the money flow goes through the payer and then it goes back to the user again. if you look at this model, you will see that it's not the customer who is going to be accused here. It's everyone in this room. Because payers are nominated there to take care of the risk. And the more efficient they are in controlling the risk, the more resistant they will be in terms of inflation. So they will be less exposed to the inflation. In the same time, providers at the same time, if they are following some standardized, normalized pathways and getting out of this culture of defensive medicine or being driven commercially, you can see that the resource utilization in healthcare will be more modest and less vulnerable to the healthcare inflation.
But let me just interrupt you here, and before we move to the providers, talking about the payers. So payers, because they have low margins and they are nominated to manage risk, they need to resist price inflation, all right?
Exactly.
But price inflation sometimes are coming due to cost on the provider side of things.
It's not only the payer, Dr.
I understand, but just let me ask you the question. So the payer at this end here, when the payer now is trying to not accept an increase in cost and keep premium at a lower level, he is at the same time, the patient also is not, there's no benefit here because certain services will not be provided to him.
Yes, no. Well, actually, the basic model of paying or funding or healthcare insurance is to grant access to service wherever and whenever.
Okay.
Maybe they will be demoted in terms of level, so instead of going to a 5-star hospital, it will be a 4-star hospital. But again, this is not the concept. This is what we are doing today and what we are planning to do in the future. However, if we need to control pricing, we know perfectly that historically and in other more mature markets, it never worked this way. It has to work through a co-joint venture or co-work between regulator, provider, and payer to regulate the practice. And when I call practice, I don't mean provider only. I mean provider, user, and payer. This triad has to be connected with each other. It's not about providers talking to each other or talking to each other with the regulator. It's about the provider, payer, and regulator being a part of a working group to control inflation. Because what will happen in the future? This exposure to inflation will continue. Yes, at a slower pace, regulators will put their efforts down there to make everyone happy and to grant access to the users to the healthcare facilities, but it will happen. And you might reach a point when the payer is going to load premiums at a way that will make it hard for purchasers to purchase this product. Or they want to downgrade the product in order to make it affordable. This is not what we need to do.
But also from a payer point of view, and taking me as an example, and this question is to you and also to Andre if you would like to comment on. Me as a patient, okay, I don't mind paying a little bit extra as long as I'm getting the service. The problem probably, which I have let's say seen, is that there is a competition on price rather than a competition of servicing me as a patient.
Thank you very much.
Okay.
Yeah, the truth is that we have price competition, big time. But until when can you afford to pay more? Until when? And if I leave myself, and I think that this is not even the vision at the level of the regulator. If we continue uploading premiums forever, certainly there will be a point when access to healthcare will be very expensive. And this is not what we are aiming for. So in order to cater for the long-term vision, which is granting access to everyone, to all facilities, there should be some thinking out of the box and reaching out a solution where this triad is working together. And let me just simplify for you. I know that Dr. Haider has previous experience with NHS. If you look at the healthcare system in UK, you will find that you have primary care facilities, then secondary care facilities, then tertiary care facilities. In the market where we are talking about, in Saudi, in Dubai, in GCC, Middle East, it's a free roaming market. So I can go for a simple tonsillitis to American hospital, city hospital, Saudi German hospital, where the elite doctors are there, the elite facility. Maybe I don't need this kind of care. This is one part. So the culture and awareness of the user shall be built on. And I believe that Ijada, as one of the initiatives, can highlight and can feed on this direction. Again, working between payer and provider, there shall be some agreement. We cannot continue forever paying a fee for service.
I understand.
It's not sustainable.
I understand. Mr. Marwan, utilization. You have the high experience.
First of all, let me make a few comments, please, if I may. We talk to each other in the United Arab Emirates. Let it systematically. If I may, if I may,
Not one-on-one.
if I may continue, please. Yes, we talk to each other. We talk to MOH. I am part of committees in MOH where I see DHA and share the health authority and DHA and MOH sitting on the same table.